Hello, my name is Tiffany Johnson Lewis, and this is my health education project for diabetes management um, for Kansas. I want to start off giving you a couple facts about diabetes. Around 1 in 11 people in the United States have diabetes. Research shows that although there is no cure for diabetes, a healthy diet, physical activity, and medication adherence can prevent or delay complications of diabetes. One of the reasons that I chose diabetes and diabetes management is because just in Kansas alone, um, the prevalence of diabetes among 18 adults 18 years and older has been increasing. Between 2000 and 2010, there was an increase of 42% of diabetes among adults 18 years and older. The educational objective I chose from Healthy People 2020 is as a community, I think we need to reduce the annual number of new cases of diagnosed diabetes in our community. And in order to address this objective, one of the interventions, I want to engage community health workers. Um, Community health workers is a new role that's up and coming. A lot of public health agencies where I currently work, we have started using community health workers. And community health workers can deliver these services and interventions through one-on-one interactions or group sessions, which take place in the patient's homes or community or clinical settings. Community health workers may work alone or as part of an intervention team, which can be comprised of clinicians, counselors, or other health professionals. So how our community health workers, they work with behavioral health, they work with the clinicians in whatever specialty the patient is seeing. And what they do is they go in and include education, coaching, social support to improve diabetes testing and monitoring. They talk about medication adherence. They talk about diet and physical activity. They talk about weight management. One of the programs that we're piloting is we have diabetic classes that are taught once a month. And they focus on a different ethnicity each month where they come in and they talk about the types of food that certain cultures eat, like the Hispanic culture may, and they try to um, monitor their eating based on the current diet they have, because studies show if you try to change their diet completely, it won't work and the patient will probably not adhere to it. The supporting research, oops, guys, I'm sorry. Um, I looked at the Community Prevention Service Task Force recommendation based on evidence from a systematic review of 44 studies, and 38 of these studies included studies and interventions that engaged community health workers, and the overall finding demonstrated that interventions engaging community health workers improve the A1C and fasting blood glucose and reduced healthcare use among participants with diabetes. So it has been proven in 38 of these cases that with community health workers actively engaged, going into the patient's home, teaching them how to cook with what they have, having these classes, you can see better control in their glucose, which may not drastically lower the A1C, but lowers it enough that you know that it is effective. The outcomes that I want from engaging community health workers is an improved blood glucose level control and A1C control, and reduce healthcare use among diabetes, like ER care for spikes in blood glucose. We also know that diabetics have a direct correlation with lipid issues or cholesterol issues. So I want to make sure that that also will show improvement in the lipid control in patients with diabetes. And then you want to see overall improvements in health behavior outcomes, increase in physical activity. Most people or we were talking in our one of our meetings that most people say, "Oh, you just have to do 30 minutes a day." Well, maybe that patient isn't there for 30 minutes or hadn't gotten to that point yet. So start them off in small increments, baby steps to get them to this. If the patient is obese, you're not going to get 30 minutes of walking, so be realistic with your goals and say, "Hey, start off 5 minutes a day and gradually let them build it," because what you don't want to do is make them not want to do it from the start by saying, "Hey, you either do this 30 minutes or not, or you don't." So we're trying to approach it a little differently at our clinic in particular, making sure that they start with baby steps, start with the foods they already eat, get a good diet based on the foods that they already eat, cutting down portion sizes, and starting activity where they are. So meet the patient and choose the care plan where the patient is. If how will we evaluate the effectiveness? Well, we'll evaluate it because hopefully over time we'll see the new cases of newly diagnosed diabetes decline. We'll see that the A1C over the 3 months will kind of start to decline as well. And we'll also have patients start keeping a food journal or an activity journal and see trends. See if you can see trends of things that may trigger them to eat a little bit more or a little bit less. Things, stress. We encourage our patients to journal anyway. So hopefully we can do this and you'll notice your trigger points, what they need, what they don't need to get overall effectiveness and a better evaluation. For me, in Lawrence, the community strengths and limitations. Well, the local hospital here in Lawrence, Lawrence Memorial Health, hosts a lot of education events. So that's one thing that I can say that they have working in their favor. Plus, Lawrence was named the sixth best city for biking and the places for bikes. So, um, there are walking trails here, there are biking trails. Um, but I know as a community we can do more. I want to engage our public health departments, and we have a federally qualified health center here as well. Engage them to work closer with the community health workers, get community fairs, maybe foster a community garden. We don't really have a YMCA here, but we have Rock Chalk Park, which is free for most for all residents here, and there's a small fee for residents that aren't here, but host more classes there based to we have a high Native American population, maybe going out to Haskell University and talking with that population and working hand in hand with KU because we have the University of Kansas here. The one limitation that I talk about when I talk about Lawrence is there's still much work to be done regarding health equity and cultural competency. And I think that if they can learn how to meet the patients where they are and they can learn to foster those relationships with the patients, I think the patients will come and they'll be more apt to engage and help in the community, and they'll be more apt to learning because if we recruit staff, equitable staff that looks like them, they'll be more apt to willing to learn from that. Or if you go out into their communities, they'll be more apt to take direction from you because until they know how much you care, they don't care how much you know. Lastly, here's my references that I use, and I hope you guys enjoyed my presentation. Thank you.